I think we better start. So this is the upper and lower GI session, and Professor Amjad Pervez is chairing the session with me. I'm Dr. Shaukat Khanum, consultant at Shaukat Khanum. So our first speaker is Dr. Farhan Rashid, and he's a consultant surgeon at Luton and also at Hammersmith Hospital, NHS in England. So he'll talk about recent advances in esophageal gastric cancer management and minimal invasive techniques in upper GI surgery. Welcome, Farhan.
Thank you. It's an absolute honor and privilege to be invited by the institute where my surgical training career started about 24 years ago. I spent about a year here before moving back to England, where I did my basic surgical training in Midlands with a higher research degree and was fortunate enough to get trained at 4 esophagogastric cancer units, including Cambridge, before getting appointed as a consultant. My esophagogastric cancer resection work is based at Hammersmith Hospital, and I do my bariatric work at Luton and Dunstable Hospital. I'm very privileged and honored to be among colleagues who are experts in their field, including George Hanna, Krishna, Chris, Stefan, and Stefan has been trained by Professor Nick Menard in our unit. As far as the bariatric team is concerned, we are highest volume center in the country, and two of my colleagues, we both do cancer as well as bariatric. The reason I'm showing all this because there's a lot of transferability of skills, what we have learned from bariatric work, which can be utilized in advanced upper GI work as well as esophagogastric cancer resections. When I was given the title by Shaukat Khanum, I thought England is far behind in terms of laparoscopic work for esophagogastric cancer work. This is an editorial I wrote in 2016. This is the time when laparoscopic work was obviously picking up. I looked into the data from 2011 to 2013. There were at least 287 gastrectomies were performed with minimally invasive approach. That included the ones which were converted from lap to open, out of total of 1,806 gastrectomies. So it still amounts to be around 15.9% of the total procedures. However, the criticism comes as to whatever we do in that part of the world, is that applicable in this continent? Obviously, there are resource limitations. The disease etiology is different. The patient presentations are different. There are 2-week wait pathways in United Kingdom. NHS is very proud of it. However, does it really make a difference in the outcome in upper GI and lower GI cancer? This is what we published. So keeping all that into mind, the most important factor still remains as to what is the main outcome we are looking for. Obviously, in our UK practice, we are all accountable as to what our mortality figures are. This is a year after I started as a consultant. The colleagues were very nice. They were giving me easy cases. But if you want to get involved, especially talking to trainees just a few hours ago, I think at the beginning you have to be selective and then proceed accordingly. This is a study where they looked into mortality from esophagectomy and compared it from high-income countries to low-income countries. Pakistan was part of it. Obviously, we are excellent surgeons, but we are resource limited. Not necessarily Shaukat Khanum, but many other institutes across the country. And it's how we rescue our patients when we run into trouble. That makes a difference. Disease etiology has changed. Earlier on, the gastric cancer was more distal. H. pylori has migrated. And we are seeing more and more of esophagogastric junctional cancers. Before you adopt any technique, whether you want to tackle them laparoscopically or open, we need to know what the nodal disease or nodal spread is like. Is it infradiaphragmatic or is it supradiaphragmatic, and approach accordingly. And same holds true for Sievert 2 and Sievert 3 disease. The basic thing about upper GI surgery is table positioning, which we have learned from our bariatric work, that if you can keep the head end as high as possible, your hiatal dissection is easy, your life becomes easy. It can, sometimes there are situations as if the patient is standing in front of you. One thing which I noticed, that as an upper GI surgeon in England, we are supposed to be JAG accredited to do endoscopy work, which we don't train our surgeons in majority of Pakistan. Because if you know how to endoscope on table, you exactly know where the tumor starts and where it ends. So doing an endoscopy intraoperatively is something which is very basic, but makes a huge difference. Your operative approach may change. You may have decided to open the chest at the beginning, but you may be able to deal with the esophagus from abdomen and prevent morbidity. I think the first laparoscopic esophagogastric procedure which really took acceptability in United Kingdom was the laparoscopic mobilization for gastric conduit, which probably holds true. I think that is the safest option to do. And as long as we are careful to prevent injury to the epipoli, we are absolutely fine, and that conduit will survive. I think that is the first step we should do. Patients who had lap-assisted ivolus esophageectomy have a much better outcome as compared to open abdomen and open chest. Mobilize the anterior peritoneum onto the duodenum as much as you can so that the pylorus can reach up to the GOJ. A lot of criticism goes on laparoscopic OG resection work, and that mainly comes from positive circumferential margin. And I'm sure my colleagues will agree that esophagus doesn't have much of the adventitia around it. So how do we achieve it? I mean, this is a benign case right now. And this is how the intrathoracic stomach has been reduced. You can see the aorta, you can see the esophagus, you can see everything. What else can we take so that our circumferential margin doesn't come back as positive? What we have learned with the passage of time is, even if you don't feel that the tumor, this is a T2 disease, if you don't feel that the tumor is invading around the wall and it's not a T4 disease, still take a crus of the diaphragm. The criticism was, oh, we've taken the crus and patient had a herniated colon day 4, day 5. That has happened. We have taken patients back to theater. But if you are careful and if you are unhappy about it, you can obviously put a one single suture at the bottom end and prevent that herniation to happen. But by doing this, you are preventing getting a positive circumferential margin, because it's all about or not resection, zero mortality, no leak. So each step which we take makes a difference. Now, the next question comes that you've done the circumferential margin. What about the precardial fat? How will we tackle that? Obviously, laparoscopy gives you a much better view in terms of how, when you go inside the chest, you are able to access where the pericardium starts, where the pleura starts. If you make a hole in the pleura, obviously fine. We're going to do a cancer work. We're going to either thoracoscopically deal with esophagus or open chest. But this precardial fat, with number of cases, one learns is around the planes around it, and you're able to dissect this precardial fat till you to reach up to the pericardium. That's the only way you can make sure that our nodal involved nodes around the precardium are all taken out. I think the white bit is the precardium there. Now, next comes the nodal disease. We're going to talk about prophylactic gastrectomy in a minute. You can do a tube operation, find the vessel, cut it. Maybe that is something which some of us may have done it at the beginning of our learning curve. But as time goes along, it does become bloody. I have not edited this video at all. And once you see a lot of blood, it does not make a difference. You need to learn around it. It takes a bit of a time. The operating time is much more than what we normally get, but it's doable. You will be able to see the trifurcation at some stage. You will be able to do the same lymphatic node yield as you do in open surgery. The other problem in the learning curve for any upper GI work was anastomosis. So from the bariatric work, majority of our work is anti-colic GJ anastomosis. And when we do cancer work, we are very pro retrocolic anastomosis. It empties better. It works beautifully. But what we have worked out is if you are used to anti-colic anastomosis, like for this bariatric procedure, and you've done a near total gastrectomy, and you want to use the same technique, as long as you've done it in the right way, it will work out. And the introtomy can be closed with the non-absorbable barded sutures. So this is quite possible for you to utilize this technique into the cancer work. The other criticism I was speaking to my colleagues at dinner last night is about feeding tubes. I think this is a technique I've learned from one of the trainees of Professor Manard here. Feeding jejunostomies. We simply use 2 sutures, make the needle go in, make it straight, let it run past. Because feeding is very important. If patients get a subclinical leak and you want to keep the nil by mouth for 7 days, 14 days, like your patients are going to Musafir Khana afterwards as well sometimes, a feeding jejunostomy is a much better option. Although we have evolved in our enhanced recovery pathway, but for our esophagectomy work, we are still putting feeding jejunostomies for every patient that comes in. They get pump trained, and in the preoperative workup, we have already told them as to how to look after their feeding jejunostomy tubes. And the other thing is closing the defects. I think we've learned from our bariatric work, closing the mesenteric defect and the Peterson defect, and why not to do the same way in our cancer work? It will help you prevent internal herniations post-op. It will help you prevent the morbidity of the patients post-op. So you can close the mesenteric defect and you can close the Peterson defect at the same time. What about the thoracoscopic anastomosis? Obviously, that became a challenge using a CDH, anvil, higher leak rates. So why not use the same linear stapler in the chest? And by having an NG in the esophagus, having a stitch at the bottom line, at the lower wall, and pulling them together, and then closing them with a 3D barred suture. That is absolutely possible. And obviously, I can't guarantee there's no 100% leak. Leak can happen, but that is a technique which is quite simple and can be utilized. For the neck anastomosis, obviously, this is what we published when we were in Cambridge. Every trial which has been published on recent advancements in upper GI cancer management, they have a different primary and secondary outcomes. Looking into class 01 Logica, they are either looking into disease-free survival or hospital length of stay. So it's very important what we are trying to achieve and what sort of treatment they had beforehand. So from prevention to potentially curative and palliative therapy, we must understand the genetics of both the patient and the tumor. Our most effective strategies to date emphasize that one strategy does not fit on all. Obviously, nodal disease, no compromise on it. If you're going to leave a disease node behind, better not do laparoscopic work. I had an opportunity for a short period of time in my career to come and work at Shifa. So I came in and a week down the line, they said, oh, you're a laparoscopic upper GI surgeon. Can you take it out laparoscopically? I said, no. So there are limitations. Please don't embark on those journeys. It's a GIST which comes out open. He had a 36 units of blood transfusion, couldn't afford angioembolizations, has been on neoadjuvant. We all know that D2 has a better outcome than a D1. Starting point for the trainees who want to embark from open surgery to laparoscopic surgery is probably a subtotal gastrectomy, which is the safest option. A GIST, which is also a safest option. Obviously, there are certain guidelines. This is something we have writing on guidelines for GIST. This is the pathway which we use. Our program, prepare program is well established. We have different protocols for total gastrectomy, for subtotal gastrectomy, and esophagectomy. This is something I'm very passionate about especially when we come to Pakistan. So a lot has been talked about, especially in the HPV session about an hour ago, that all our patients are younger. So we are doing everything, whatever we can, to treat them once they get diagnosed. But why not identify them once they have not been diagnosed? So I was working at Cambridge, and 6 patients came during my tenure over there, and 4 of them had a Pakistani surname. So their heritage was from Pakistan. So the hereditary diffuse gastric cancer with CDH mutation, obviously they have a high propensity to develop cancer. 80% of them will develop diffuse gastric cancer. And the only treatment which is available is prophylactic gastrectomy. Obviously, they need workup. They need mapping, endoscopic biopsies. When I came to Shifa, I identified one family. I tried to educate them as much as you can. But I'm very hopeful that the Shaukat Khanum is the forum which can take this initiative. They have the huge database. This is probably the largest database in this country. Why can't we identify them and offer them a prophylactic gastrectomy? All of them done by Professor Richard Hardwick. And all of them just need a D1 gastrectomy. They don't need a D2 gastrectomy. And you are preventing 80% chance of them developing gastric cancer afterwards. Obviously, in that era, this is 2016, it was all done open. It can definitely be reciprocated as a laparoscopic procedure. The other thing is obesity is on rise in this country. There's a lot of bariatric surgery which is happening in this part of the world. There are lots of patients with sleeve gastrectomies who have developed esophagitis, who have developed Barrett's, although Barrett's is not that common. This is the systemic review and meta-analysis which we published, that if you do convert them to Roux-en-Y gastric bypass, then there is an improvement in Barrett's epithelium afterwards. How did we rescue our leak patients? We used endoscopic endovac therapies, but nowadays I think stents have evolved. It is very costly in certain parts of the world, so it's not that it can be used in every institute. Otherwise, a simple NG with a sponge on it and connected to a sucker will work, and you will be able to treat your leaks. Our prepare program. So lots gets talked about enhanced recovery after the operation. But Krishnamurthy, one of my colleagues at Imperial, he runs an excellent prepare program. They have identified patients who are inoperable because of fitness and give them a dedicated plan as to what exercises they need to do and how can they improve their fitness. And I have witnessed elderly people become from being an inoperable stage after your adjuvant and prepare program to become fit to have an operation. And their inoperability was purely because of fitness. There are digital apps. They have been compliant with it, and it does make a difference. There's a 140% increase in step count within the first week of the program. This is something which can easily be replicated even in a very uneducated patient population. We all know that the greater adherence to the exercise program is associated with less impact on sarcopenia, and we all know it is how important it is for our OG resection work. This topic is very close to my heart. This is my research. All the patients who have equal exposure to all the risk factors for OG cancer, why we have a higher incidence of esophageal cancer in males as compared to females. I took these cancer cells while I was in Nottingham University, grew them, treated them with tamoxifen, flutamide, took their blood sample, looked into their serum estradiol levels, and I've managed to identify that there is a differential expression difference between males and females, and there are potential targets which can prevent angiogenesis, proliferation, apoptosis, and transcription. We all know that 20 years ago, I don't think so we were hearing about giving tamoxifen to breast cancer patients. Is it something we are missing out on esophageal cancer as well? Now, coming purely to the benign disease, once you are used to upper GI laparoscopic work, this is our series from our hospital for gastric volvulus. All the patients who come in with the twisted intrathoracic stomach, decompress them, put an NG, and do them laparoscopically next day. These are elderly people who will do better, and it's all well proven. Even esophageal perf, we looked into it. It's not uncommon during the on-call to get an esophageal perf. I'm sure that you get it in Oxford, and likewise we get it in Imperial. Our catchment area is 4.5 million. So during your on-call, getting one call for esophageal perf is not uncommon. Certain situations, you can laparoscopically deal with abdominal part and may leave a chest drain and come out, and you can approach the lower esophagus. So when I came to Shifa, the reason I specifically left it, this is a trainee who dealt with me with a blunt trauma to diaphragm. And the most proud thing is that he managed to publish it before I left. This is something we need to encourage our trainees over here to please publish whatever they do. Pakistan needs to be on the map for publication work. And then obviously patient came in with a previous liver transplant and they wanted me to deal with it laparoscopically. He's non-affording metal ports, no disposable drapes. You can think about it. It can be done. Can be done. There's a lot of progression in the last 1 decade about moving towards laparoscopic OG work. And I feel that in coming 1 decade, I think this will become norm. I can't end this talk without saying thank you to 2 mentors. Dr. Amar Ali Sayyed is the person I saw my first esophagectomy in my life. He doesn't probably realize it, but he does have a charisma to impress others. And that's how I carried on. Next one is Mr. Iftikhar. He's been my mentor in my research and higher surgical training. We are 3 upper GI surgeons, and we have developed this charity hospital in my hometown, which is exactly like an NHS facility and provides free care to all the patients. You couldn't dream about doing sebaceous cysts, but we have done laparoscopic distal gastrectomies free of cost to the patients. Thank you.
Thank you very much, Farhan. We'll take the question at the end.
Thank you.
It will work. This is working. Okay.
So I have a pleasure to introduce the next speaker, Professor Nick Menard, who would speak about functional outcome following esophagectomy. So floor is your professor. Thank you. Thank you for coming.
Thank you very much. And thank you for the invitation to come. It's my first time to visit Pakistan and I'm loving it and would love to be invited again, please. So thank you very much. So functional outcomes following esophagectomy. So as way of background, I'm an upper GI surgeon in Oxford. I set up the esophagogastric cancer service there back in 1997. And I guess it's fair to say over the course of my career, I've become more and more obsessed and focused more and more upon functional outcomes from this surgery. Now, if you ask surgeons what outcomes are most important from esophageal, they'll come up with mortality rate, length of stay, nodal yield. Everyone's obsessed with the amount of lymph nodes you can remove, anastomotic leak rate, 1 year, 5 year survival, and numbers of resections they're doing. And there's a lot of competition amongst surgeons to do more than anyone else, to get more lymph nodes than anyone else. But if you ask patients, they probably won't recognize the same things. Yes, they don't want to die from their operation, but they perhaps won't be as obsessed with the surgeon's mortality rate as the surgeon is, or their leak rate, or their nodal yield. They do care about getting cancer recurrence, but they care about their quality of life and controlling symptoms. And it's all about survivorship. And they want to live, but they want to live well. And I think it's fair to say that a lot of patients having had such major cancer surgery don't always live well. They might live, but not well. And this concept of survivorship is really a holistic description of all the symptoms they may have related to their disease and their surgery, related to complications, physical function, comorbidities, which may be new comorbidities, finance problems, employment, whether they can work, their relationships, their sexual relationships, their mental health, often a big problem, how they can function socially, and whether they can look after themselves and provide self-care. And this is something I think perhaps as medics we don't think about enough. And indeed, if you ask someone who's had an esophagectomy, often for several years afterwards, do you have any symptoms associated with your esophagectomy? Most of them will say yes. And we know what these symptoms are. They're often multiple. They're often compounded by the oncological treatment they've had as well, which is now the case for the majority of patients having esophageal cancer surgery. And it's perhaps not surprising. It's a highly complex operation, fundamentally changing anatomy and physiology, and it's often on fairly elderly patients who have less reserve. And certainly in the UK, we don't do much about it. We have no standardized follow-up. Indeed, the recommendations are you don't need to follow these patients up, and I'll talk a bit about that later. There's no consensus on the diagnosis, investigation, or management of these symptoms and the common problems patients get. And I think it's fair to say, certainly in the UK, there's a lack of resources, a lack of time in clinic, a lack of ownership, indeed. The surgeons say, well, that's not really my problem, or the oncologist says, not really my problem. And perhaps we should have gastroenterologists looking after these patients. And I think, dare I say it, a lack of understanding amongst many medics involved in treating these patients. And certainly in the UK, patient follow-up is very variable in terms of duration, frequency, who does it, whether it's dietitians or nurse-led or surgeons or gastroenterologists, and should it be done in the resectional centre, or should they be sent back to their referring hospital for follow-up where they perhaps don't have the expertise to deal with these? And I would posit the question, are surgeons the best people to follow these patients up? So Shiraz Markar is a colleague of mine in Oxford. We tease him saying he's becoming a bit of a global superstar in esophageal surgery. And he has, as a registrar, he had produced far more papers than I had as a consultant. Now he's a consultant, he's becoming stratospheric. One of the very first big studies he did was the laser study, the lasting symptoms after esophageal resection, published a few years ago. And this was went through a Delphi process, and it looked at evaluating the incidence of persistent symptoms in long-term survivors, those that have survived more than a year following treatment for esophageal cancer, and to assess the impact these symptoms would have upon the health-related quality of life for these survivors. And they looked at 876 patients in about 20-odd centres and found that, again, consistent with the literature, about 67% had significant symptoms which impacted on their life. It was 3 rounds of a Delphi process, 20 European centres, and involving significant time in patient workshops as well. And this just highlights some of the findings. So the proportion of patients experiencing these symptoms, 35% get some degree of satiety, early satiety, which impacts on their quality of life. 30% feel tired consistently, have low mood, reduced energy, can't do what they used to do. Sorry. And these had a substantial impact on quality of life, particularly heartburn, low mood, and lack of energy. And the symptoms tend to be clustered into 6 groups. Those of lethargy, dumping, lower GI symptoms, probably because of their vagotomy, musculoskeletal symptoms, and then particularly something I'm interested in, and I think surgeons can do something about, are the symptoms of regurgitation and reflux, and then swallowing and other problems related to the conduit. And I'm going to talk a bit about these later, because I think the way you do your operation, and again, this is something I've focused on a lot in recent years, can impact on the prevalence of these symptoms. They followed that up, Shiraz, with the LASER study, which was using 6 cardinal significant symptoms to develop an app, to develop a predictive tool that could predict health-related quality of life beyond 6 months. And that's using chronic pain, heartburn, loose bowel motions, low mood, reduced energy, and then bloating or cramping, together with early satiety after eating. What about psychiatric morbidity? Very significant. This was a paper from about 10 years ago looking at post-operative psychiatric morbidity in patients undergoing all forms of GI cancer surgery. And 10% of patients developed some degree of psychiatric morbidity following their surgery, predominantly anxiety and depression, but also other psychiatric problems as well. And you won't be surprised to know that esophagogastric cancer surgery carried the highest risk of all other GI tract cancer operations, with an odds ratio of 2.55. And if you had a newly diagnosed post-operative psychiatric morbidity related to your surgery, you had a significantly increased risk of 1-year mortality. And we've talked about the variety of symptoms patients get. And on the right-hand side of this page, you can see all the symptoms people get from various esophagogastric cancer operations. And if you have 2 or 3 symptoms, you are very highly predicted to get particularly post-operative depression and anxiety. So it is a major problem. And again, it's related to the symptoms they get from our surgery. So what can we do to improve function? And again, this is something I've particularly focused on in the latter part of my career, because I do believe not enough focus is paid on this, and notwithstanding the potential huge benefits from robotic approach and minimally invasive approach, which we've embraced in our unit hugely, not enough attention is paid, in my view, to the way you do the operation. It's all about the approach and not how you actually construct the conduit and deal with things afterwards. So what do we do? How can we reconstruct? How can we improve things? Well, the choice of conduit, we clearly use stomach most of the time, but we sometimes use colon and jejunum. And there are specifics. We need to decide, do we use a whole stomach or do we use a tubularized stomach? The vast majority nowadays will use the tubularized stomach. And if you're going to use colon, should it be left or right colon? Should you go transhoracically, which is clearly the better approach oncologically? But when we're doing benign esophagectomy, should we do them transhiatally, leaving a pleural envelope which keeps that conduit in the central part of the mediastinum and stops it herniating into the left or the right chest? If we're going to do an anastomosis in the chest, should it be above or below the esophagus? I believe with absolute passion it has to be above the esophagus, but I know not everyone does that. Or should you put it up in the neck? And how should you reconstruct? Which route? Should you go through the posterior mediastinum, which clearly we do when we're doing a reconstruction at the same time as the esophagectomy? But if you're doing a delayed reconstruction for whatever reason, whether it's a Boer halves or whether it's a dead conduit you've had to take out, should you go again through the posterior mediastinum? Should you go retrosternal in the anterior mediastinum? Should you go even subcutaneously? And should you do a gastric drainage procedure? Should you do a pyloromyotomy or a pyloroplasty or dilate the pylorus or nothing? We don't know. We all have our preferences, but it's not strongly evidence-based. And again, should we do it open? Should we do it minimally invasively? Or should we do it robotically? So what about the gastric conduit? What do we do to this gastric conduit when we're mobilizing it, constructing it, and replacing the esophagus? Well, we know we reduce the blood supply by about 10 to 20%, and that's worst at the fundus or the most proximal part where we're doing our anastomosis. We tubularize it. You can get more length by tubularizing it, by taking a lot of the lesser curve, but you reduce capacity and they get a lot of significant satiety. You denervate it. Now, you can do a vagus sparing if you're doing it for non-oncological reasons, and that does make a difference. But if you're doing it for cancer, you have to take the vagus nerves as well. And you also disrupt the sympathetic nerve supply. It's located into thorax. The stomach is in the thorax. It's subjected to the really huge pressure changes during respiration, and that creates a pressure gradient across the hiatus. And depending on how much stomach you have in the abdomen and the chest, you will get an impact on reflux type symptoms afterwards. And of course, you're resecting the lower esophagus, you're disrupting the hiatal structures, so you lose virtually all the normal reflux barriers. And what sort of problems do they get? Well, they get pylorus dysfunction. We've talked a bit about that. Disordered peristalsis, dysphagia, delayed gastric conduit emptying, obstructive symptoms, regurgitation. You'll all recognize these if you do esophageal surgery. Nutritional compromise, aspiration, dumping. And these can all be exacerbated if you get anastomotic complications, particularly getting strictures and dysphagia. You can get very significant mechanical symptoms if you're not careful how you place your gastric tube, how you place your conduit in the mediastinum. If it's kinked or angulated, you'll run into problems. It can be constricted at the thoracic inlet. It can be constricted in the hiatus. And of course, it will become redundant. It will become more dilated. It will become more elongated. And if it's a particular problem early on, it means you've probably done the operation. You've done the reconstruction inadequately. But now we're curing more and more of these patients many of them will get very significant late redundancy. So what can we do? Well, we can construct it as well as we can. And this is what we focus on a lot in our unit. A high anastomosis, I believe very strongly, you've got to have an anastomosis at the apex of the chest, just below the thoracic inlet or in the neck. I always make a very thin conduit. I take the right gastric artery, nearly everyone, except if I know they're a vascular path, because you can make a much thinner and longer conduit that way. Avoid redundancy, resecting the fundus and making sure you position it very well. Think about the mediastinal pleura. I think for a good cancer operation, you must take the mediastinal pleura. But you then do run the risk of that conduit herniating into the left or the right chest. And if you can preserve the pleura, if it's a very early tumor, or if you're doing it for benign disease, then you keep it in the central part of the mediastinum. Think about the pylorus. Where should the pylorus be? Ideally, it should be at or above the hiatus. And what should you do to it? Should you do a pyloroplasty or dilate it? We dilate it, or nothing. A lot of people don't. And think about the hiatal cauda. I absolutely agree with Fahad. You've got to take a cuff of crura for cancer reasons, but you then got to think about how big that hiatus is. If it's too wide, you'll get herniation. If it's too narrow, then you'll get hiatal constriction, and they can be really big problems. And manage well in the early months. Really focus on good intensive dietetic advice in those first few months. If you get early acute dilatation of that conduit, that will impact for the rest of their lives. So really take your time. We don't, but a lot of units, Don Lowe in Seattle, I know before he retired, would actually keep them on long-term jejunal feeding for 2 or 3 months afterwards, restricting their oral intake to prevent that early dilatation. So in conclusion for this part, there is a large, I believe, largely unmet need. I am obsessive now, and I would urge everyone to think about conduit function and optimize it. Whether you're going to do it robotically, minimally invasive or open, very important considerations, but think about how you do your conduit reconstruction and don't compromise just to allow you to do it via a certain approach. Think about the functional outcomes, because the patient will be thinking about them for many, many years in advance. Minimize the complications, and don't forget that a good oncological operation must go hand in hand with a good functional operation. Now, I'm going to just talk a teeny bit about a trial that Shiraz has set up nationally, which I want to talk about. We don't know what the ideal follow-up is, but we should be able to determine how often we follow them up and what the nature of that follow-up should be. With dietitians there, we have a dietetic-led clinic, and they run a fantastic service, nurse-led as well, with gastroenterology support. We don't do this, but we probably should have a survivorship MDT, not just discussing the current cancer patients, but discuss all the problems they get following their surgery. Follow-up should be as long as it's needed, on demand, and we should have standardized pathways for investigating and managing these patients with their symptoms, and we don't have that. The ESMO guidance is that there is no evidence of any benefit from follow-up following an esophagectomy for cancer, and the NICE guidelines in the UK essentially say the same. They do not recommend. I know these because I was on this panel, so you can blame me partly for this, but they do not recommend any routine clinical follow-up of patients having had an esophagectomy, and we were wrong then. So let me tell you about Sarong, which is a study that Shiraz has set up, and it's a multi-center study, and it's to determine whether intensive surveillance after completing curatively intended treatment improves survival and health-related quality of life in patients with esophagogastric cancer. So there's multiple centers. They're recruiting, I think, well, I'll come on to that in a minute, but so people are being randomized either to standard follow-up, normal care, or intensive follow-up with CT scan every 6 months and a questionnaire all about quality of life and symptoms. So 6 monthly CT scan for 3 years, OGD every 12 months versus standard follow-up. There's 27 UK centres. There is a European arm as well, and they're recruiting extremely well. I mean, it started a year ago. I think they've recruited, I think they're a quarter of the way there in terms of recruitment. So, and then we will know, hopefully, as a result of this, what the optimum follow-up is for these patients. Thank you. I was hoping to be able to finish this talk by telling you that England had come to a stunning victory this morning, but of course they didn't. They were bowled out, and Pakistan's won the series. So congratulations, and thank you for a lovely time in Lahore.
Thank you very much, Professor. Thank you. So the next, the next speaker is Professor Amjad Parvez Cheema, who doesn't need any introduction. He has been a regular in our symposium, and in fact, he has been instrumental in developing the structured training for our surgical oncology fellows in colon and rectal surgery. He'll talk about MRI guided straight to surgery for rectal cancer. When and how?
Well, thank you very much. Thank you for the organizing committee keeping faith, so I can reassure Professor Nick Maynard that they'll keep inviting you unless you unless you throw in the towel. So the topic I'm going to talk about is fairly close to my heart in a way that we actually, as a colorectal surgeons, progressively, me as a trainee and then subsequently taking up a consultant job, have given up a control of our rectal cancer to our oncology colleagues, and they very happily have taken it over. And I'll go through the rationale of what MRI importance is, and do we need to sort of look at the indication of which patient we need to send them to have a neoadjuvant setting. I left NHS 2 years ago. I spent part of my month in this lovely place in Shimpalemo. This is a cancer center. I had a colorectal unit there, besides spending a week in Doha, Qatar. So you're welcome to come. Some of you may have already visited the place. It's a fantastic establishment, and they do very high quality research work too. So I actually could finish my talk by showing you this slide. Are there any oncology colleagues sitting in the audience? 1, 2, 3. Good. Excellent. So at least I have a chance to share some of this. This is a borrowed slide from my medical oncologist, Dr. Carlos. This is looking at all the trials that have published so far for rectal cancer, the role of neoadjuvant chemoradiation, to see what effect they have both on local recurrence as well as on 5-year survivals. And to no surprise, chemotherapy, adjuvant chemotherapy or neoadjuvant chemotherapy have contributed to better survival figures because that treat the systemic disease. And despite what we all have been led to believe, none of the trials have ever shown a survival advantage when radiation was looked at. So let's focus on this, so which means that radiation perhaps reduce local failure rate. And local failure rate are either because of understaging or perhaps underperformance of surgical skills. So do we really need neoadjuvant chemoradiotherapy? The answer is, if we keep producing specimens like these, we need a bit more than neoadjuvant chemoradiotherapy. This is one of the slides which I probably have shown you in the past. Someone somewhere in the world have done the first laparoscopic APR, and they sent me the picture, which was a laparoscopic port picture, to say, would like your comments. And I sort of said, I'd like to have a look at the specimen. And this is the specimen they send. So if you're producing these specimens just because you're obsessed with trying to do it laparoscopically or robotically, you are doing no good. So let's talk about this. This is NCCN guideline, most recent versions. And I would like you to focus on this part of the slide. So this is a new kid on the block, TNT, total neoadjuvant therapy. They want to sort of give all the chemotherapy up front. They're going to fry the rectum for 6 months, and then they're going to send this patient to you if they haven't responded. So look at the indication that they think. T3, NNE, T1, T2, N1, N2. So all of these patients, they want to give long course chemoradiotherapy. No mention of CRM, no mention of any other thing. So even if you have T1 to T3 and N disease, N0 or N1, they're going to have a TNT in US. And then they said the alternative is to give them FOLFOX and CAPOX and then give them long course and then restage. The reason they have put in this in national guidelines in US is that we tend to remember big centers with very high outcome, highly quality outcome data that has been published with few centers. America is very big. An average colorectal surgeon in America sees 6 rectal cancer in a year. So imagine those people in the districts are going to take rectal resection on, and they probably are going to do suboptimal job. Let's look at Europe. Europe is a bit better. They have identified this. This is ESMO guidelines for rectal cancer. They think that if it's an intermediate disease risk, which is T3AB, low, levators are clear, mesorectal fascia is clear, they are mid to high rectal tumor with no extranodal involvement, they should have TME alone. Interesting thing is here, consider doing chemoradiotherapy or short course chemoradiation if good mesorectal excision cannot be assured. So they're giving you a get out clause as a surgeon that if you can't do a nice operation, do a short course radiation. And we know this, that short course radiation and operating the next week has got no effect on the patient. It is mainly for the surgeons rather than for the patient. Everybody referred this. This is a very famous German trial where they prove that if you give chemoradiation in a preoperative setting, you have better local control. So everybody remember this paper. They all the time quotes it. My oncology colleagues keep quoting it. This New England Journal of Medicine. Now, we knew that. We memorize it. Surgeons have got very small sort of thinking timeline. We sort of remember very quickly. We are gifted with memory loss. Otherwise, we'll remember every complication. Nobody remembered this. This is a long-term data of the same trial, right? Nobody sort of quote me this figure. 11 years later, same cohort of the patient looked at, the local recurrence rate was no difference. So in a short term, when the results were good, p-values were good, you could publish it. But 11 years later, the same group look at the evidence and there is no difference in local recurrence following neoadjuvant chemoradiotherapy. This is Gina Brown's work, and this is a very important work, a Mercury study from UK. I trained in Basingstoke. I was very heavily influenced by Mercury mindset with Professor Bill Heal and Brendan Moran. They were doing radiation very, very selectively. So she recognized that it's the CRM positivity rate that makes the difference in local recurrence-free survival. This is their publication showing that if you get R0 resection, and if you have R1 resection, they fare differently when you watch them very closely for long term. So they had come up with this. This is well-published data. If you look at this, high-resolution MRI scan, if the CRM is involved or threatened, which is less than 2 millimeter, they would go for preoperative neoadjuvant therapy. If the CRM is safe, and even if they are T1, T2, T3A, B, and any stage, and low rectal cancer and no AMVI, they should have primary upfront surgery. So this is something that was practiced in UK for that matter, at least been pushed through Mercury trial data. This is their published data now. This is 2 or 3 center Royal Marsden data. This is Emmy Lloyd who published this, 378 patients, upfront TME, and they looked at their results in terms of survival. Local recurrence rate, upfront TME for those low-risk patients is 6% in their series. And they look at what we call disease-free survival. You could see the difference now. People who were low risk, you could see their survival is better. And high-risk patient they identified were people with higher T stage, EMVI being another surrogate marker giving a risk of a distant disease, CRM status. So these are the things that at the tumor deposit, of course, on MRI scan. So if you have these patients are the very patient who might benefit from neoadjuvant therapy rather than upfront surgery. This is the most recent published data from New York. This is New England of Journal again. So I'm taking it to the next step. So our medical oncology thinks that you don't need radiation. Chemotherapy will cure everything, because they don't want to give this guy even or a girl to the radiation oncologist. This is their data, but look at the case selection. Around 1,000 patients, T2 patient, N1, T3, N0, T3, N positive. CRM is all clear, but they're going to give them these 2 arms of the treatment, either FOLFOX for 6 cycle or neoadjuvant chemoradiation. And they showed that 5-year local recurrence is very similar between the 2 groups. So what they are proposing now is that these patients actually don't need radiation at all. They just need chemo. So this is something new. You may or may not sort of know this. This is 5-year disease-free survival, same group, showing no difference, neither in the form of local recurrence failure, as I showed you, or disease-free survival between both groups. This is Occam trial data. This is a German study, which actually for a surgical or rectal cancer surgeon is a very important study to look at. They look at all those low-risk patients that I mentioned, 500-odd patients who went upfront for surgery, and look at their survival figures. So local recurrence was 5.7% if they were high-risk patient, but people who had CRM clear and had even N1 disease, they had about 38% of their patient N1 disease with T3, 3% local failure rate. 5-year disease-free survival is replication of what we expect it to be. This is our data. This is in press now, so I can't reference it, but I would like to share it with you because it is gone already for second revision. In 300-odd cases that we had done in the last few years, 141 had upfront surgery. This is just the demographic of these to give you an idea that 38% of these were N-positive patient. Excellent MRI scan because the prediction of mesorectal fascia involvement was wrong only in 1 out of those 141 patients. And that's why in the previous session I was alluding to, you need an excellent MR person to guide you to do this. Most of these cases were done either robotically or laparoscopically. First 6 cases were done open before I joined the group. This is pathological outcomes. You look at node positivity, you look at lymph node retrieval. As Professor Birard mentioned, we are all sort of obsessed with the number of nodes, but it's not the nodes, actually it's the margin that matters. So in those 141 patients who went straight to surgery, I had 1 local failure, distal dissection margin positivity with a staple line catching the lower edge of the tumor. The same guy developed local recurrences requiring an amputation of the remnant. This is straight to surgery overall survival, but these are the important things to look at. 5-year local recurrence free survival in this group is 97%. When you look at disease, distant metastases free survival, I showed you 8 patients had developed distant metastases and died, 87% still alive and well. And stage by stage survival in this particular group is stage 1 is 100%, 85% for stage 2, and 76% in stage 3. This is partly technical, but mostly biological. You are operating on patients who have got biologically a favorable tumor. Your role is to not give them complication and get them out of the hospital with negative margins. I'm just gonna briefly show this. This is important. This is how you achieve this. And everybody, I have a passion for years about standardizing the operative technique, because when I was training as a trainee, I came from South Africa to England, and I saw the same operation being done in 6 different ways by 6 different consultants, and everybody made me believe that this was the best way of doing it. So this is last year in Peshawar with the Fahad and Irfan. When they hosted us, we did a live demonstration of TME. This is monopolar diathermy. You are chasing embryology. You don't need something very fancy. If you could export or explore anatomy, which we all should be able to as a cancer surgeon, you are likely to produce good outcome. I'll forward this because you probably have seen all of this. You could see the nerves now. These are the right nerves. You stay inside the right nerve package, and you basically have to just convince the specimen to leave the nerves, and this has a functional aspect. If you damage those nerves, they become impotent. If they're sexually active, they have long-term bladder problems. So it's not only just about curing patients, it's about preserving their quality of life, which has become increasingly more important as we have gone on. So a year later, this is a day before yesterday with Fatima and Ansar and his colleagues doing a similar operation 1 year later. Same instrument, same picture, same anatomy. The only thing which is consistent is the anatomy. And some of you might say that daily we haven't improved in a whole year of practicing this. We're still doing the same operation, the same. That's the whole idea. The idea really is to chase anatomy and not to create something that doesn't exist. If you could do the operation going around the envelope in a bloodless field, you then perhaps would have done some good. Biology wins in the end. You can't predict any of that, but you could help doing this. Whether you do it with robot, whether you do it laparoscopically, whether you do it in Lisbon, whether you do it in Karachi or in Moscow, the rectal cancer predictably behave the same way. They would do it exactly the same way, and you have to just reproduce the same operation. Precision is important. I emphasize more and more to my young surgeons who operate with me, either with lap or robot, or for that matter, open. Anatomy, learn anatomy. Don't get obsessed with a new tool that would do Bill Heel's operation. I'm afraid there is no button as yet on the robotic system that you can select and say Bill Heel's operation. You have to sort of reproduce the same operation chasing anatomy. Our results, some of you may have sort of seen this in the past. This is standardizing laparoscopic TME approach. I know Jamil's going to talk about this, so I'm not going to waste too much time showing you this data. Important thing was this, that even when you do non-selective first 300 odd cases as a consultant, this is first 5 years or 6 years of my consultant practice at Portsmouth, 23% had chemoradiation. So even in those days, we were selecting patients with clear margins, EMVI negative, and regardless of end stage, we would offer them upfront surgery. We would not send them for downstaging neoadjuvantly. This is what you're all after, really. Take pictures of your specimen. Keep a record of what you have done, because this may be just 4 hours of your operative life that you have given away to somebody, but those 4 or 5 hours are the most important 4 or 5 hours for the patient. They want this operation once in their life. So critique yourself, look at your pictures, and try to produce the specimen boringly similar, regardless you do it open, lap, robotically. Whatever works in your hand is the best option for the patient. And you got to do this over and over and over again. Only then you would start knowing or noticing what is suboptimal or substandard. So in conclusion, Mr. Chairman, ladies and gentlemen, I just think that standardization of operative technique holds the key. But this has to be underpinned with high quality imaging. We really need to improve our MR reporting, standardized fashion, and having a pathological specimen being looked at in the same way. One of the reasons Professor Bill Heel has published excellent outcome over the years is that he has standardized all MR imaging, as well as Phil Quirk from Leeds have established a cut-up method of doing the specimen. So you recognize when they say CRM and when they talk about margins and so forth. Remember this, chemotherapy or radiotherapy can never compensate for bad surgery. If you are relying on chemo and radiotherapy to compensate for your bad surgery, then it's not a good option to be. Make sure the first operation works, because second operation seldom works. Third operation perhaps never works. So make sure that you get it right in the first go. Surgical skill sets need to be improved with structured training programs, so we can produce excellent outcome for our patients. You are welcome in February. There's a very important international meeting. I hope hopefully to see some of you in Lisbon. Thank you so much for your time and listening to me. I'm happy to take any question in the end. Thank you.
Thank you very much, Amjad. As you said, we'll take the questions at the end of the session. So the next speaker is Dr. Jamil Ahmed. He's a consultant colorectal and robotic surgeon at Northampton General Hospital in England. And he will talk about robotic versus laparoscopic rectal cancer surgery. Are we on the right path?
Thank you very much for giving me the opportunity. It's a pleasure to come again, and Shaukat Khanum. Last time I came to Peshawar, and this time again. And topic given to me is about robotic versus laparoscopic rectal surgery, and are we in the right path? This is where I work. I work in Northampton General Hospital, one of the oldest hospital in country, and Northampton is in Midlands, west of Midlands. It's famous for shoes and leather products, and it's been one of the iconic thing for Northampton. So what we're going to look at? We're going to look at the robotic and laparoscopic techniques, and to look at current trends, evidence, and future direction in colorectal surgical practice. I think this slide is already summarizes the talk of Professor Nick Maynard, Professor Amjad and Farhan, that our journey is from taking the disease and then to prevent disease, as well as to preserve the function, and that is very key thing. And we are trying to look at the various way of doing it, either giving upfront chemo radiation, or trying to get those sort of methods to do the surgery so we can improve those aspects. So those are the two important tools or modalities to perform minimal access surgery, which is laparoscopic and robot. And in the future, we are heading towards super minimal invasive surgery, and probably who will be having a more of more of the benefit of preservation of function. So looking at laparoscopic, when it started in 1901, George Killing gave the idea of laparoscopy when he said as a cilioscopy, and it takes 82 years to perform first laparoscopy, which was performed by Sims, a gynecologist, and he had a very hard time from his colleagues to doing that and stepping into the general surgery territory as a gynecologist. But next 40 years, the number of evidence being produced and the George Killing's idea of less pain, low number of length of stay, and the no insigne hernias and early recovery get into the evidence, and laparoscopy become a very standardized approach for many procedures, and are perhaps all of the procedures which we do in various cavities. It gives you a tactile feedback. It is easily accessible. It has proven through many randomized controlled trials that laparoscopy is safe, and it is doable, and as the previous presentation were told. Now, we do have a problem with laparoscopy. When you look at the views in pelvis, you have a limited view. We have a person who is holding the camera and you are dependent on him. And you have an issue with the dexterities, and especially when you are doing or performing a procedure in a small cavity. Surgeon get fatigued, and there's a learning curve and high conversion rate. And these are the aspects which really made us to think about another tool, which is a robotic assisted surgery. Now, this idea was there for a while, and it took a good, again, 70 years to become a first robotic cholecystectomy, which was performed in Belgium in 1997. And then intuitive surgical established in 2003, and robotic assisted surgery become another tool for next 20 years now, and it is offering you a enhanced view with the 3D images. It gives you a precision, which Professor Amjad was talking. It has given you the dexterity back, your hand back to the abdominal cavity, which you used to use for our open surgery. It has given better ergonomics, and where surgeons is sitting comfortably and performing the procedure. It's a lot of other benefit, such as low pain, less pain, low blood loss, and obviously it given a lot of opportunities to incorporate AI and perioperative navigation, which we will talk about later on. So this is the hand which you use in an open surgery. It gives you a 360, a robot gives you 360 hand motion, and you can perform surgery in a tight, in a narrow place. Surgeon is sitting very comfortably, and obviously your assistant is not stressing, and he's also sitting and watching you and giving you help. The tremor being filtered when you are performing surgery, and the motion inside is only 2 centimeters as compared to the motion you make on your console. These are some of the my short videos looking at how precision can help, and robot can make things easy. Obviously, these are the videos which or contributed by training from Professor Amjad. And you can see that it gives you a very good view and very easy access to the pelvis with the robot. It also gives you the confidence to dissect around the vessels more precisely and preserve and take the lymph nodes as you want. And obviously, the anastomosis becomes much easier if you want to do with the intracorporeal approach. It also gives you an opportunity to perform the operation with a standardized technique, because you have to put these ports in a certain way. We have a problem with this, as any modality you're going to use, it has some associated risk with it. And in this, with this cost is this comes with a big price tag. It has some issue or some learning curve. It is setup takes bit time, and there is a lack of tactile feedback, and obviously training and mentorship is a problem. So let's look at the what evidence we do have. It depends upon how you look at and interpret these evidence. These evidence can be sometimes contradicting one trial to other. And I will start with the roller trial, which was one of the initial trials, and it concluded that there was no difference in both laparoscopic and rectal resection. But I will say that in that era, when the roller trial was done, the people who performed that surgery had a much less experience in the robotic approach, and though they were called that they have gone above the learning curve, but they were not as master as the people who are been using this robotic surgery for last 10 years. And my interpretation for this trial may be that actually robotic approach is safer and equal to laparoscopy, and rather than saying that it is not giving any advantage over the laparoscopic approach. People have produced number of case series, and time and again they prove that it gives you the conversion rate. Generally, when you do the laparoscopic approach, rectal cancer surgery depends upon again which country and which evidence you look, it varies between 15 to 25%. And in the robot hand, it consistently produces that it is less conversion rate, better circumferential margins, and obviously time was an issue, still more time. There's another meta-analysis which look at the number of other factors, such as sexual dysfunction, lower urinary tract dysfunction, and blood loss, and that was all better in the robotic approach. It do have again some time which is proven which has been shown in the previous studies. So this is the color trial, which I wanted to just highlight, which is a Korean trial, which showed that there was the TME, quality of TME was, there was no difference between the laparoscopic and the robotic. But you must remember the patient set and the experience of those surgeons, and they've been always a different, their quality and their skill set and the patient set is different. However, they also said that length of stay, circumferential margins was better in the robotic group. This is another meta-analysis which showed that there is a improved resection margin and shorter length of stay in a patient with a robotic approach. And the rest of all parameters remain fine in these 32 trials which they included in this meta-analysis. So this is a real trial. I think this trial has tried to address a number of flaws which been there for a number of other RCTs. So they selected the very experienced surgeons who had more than hundreds procedure done in both arms, and they found that the oncological quality of resection was better in robotic group. They had a low resection margin positivity and few conversions and lower intraoperative and postoperative complication in those cohort of patients. So this is another aspect which we looked under supervision of Professor Amjad and look at the function, which is one of the important aspect for the surgery. And we found that although it's a retrospective study and not randomized, but we found that there was a better sexual function in male patient who undergo robotic approach. High-risk patient is another cohort of the patient, which we looked at again at Portsmouth when I was a trainee with Professor Amjad. And we found that the high-risk patient has actually get better served with robotic approach. And this is also, we wanted to highlight that if you want to use the robot for a set of patient rather than everybody, this is the set of patient which would use. This is to give you a bit of idea. Obviously, you have seen the Professor Amjad's videos. So this is the right side is my low anterior section on a female patient with BMI of 25. And you can see that it's even a person like me could do a very good job. Because the patient BMI and view and everything is very favorable. And the left side, you see a robotic approach, which I did a patient 6 months ago. It's a male patient, and his BMI is in late 30s. And this is where the game is. If you do not, obviously, you have to use the tool. Operation remains the same as Professor Amjad alluded to in his talk, but his tool can help you to perform the same approach, same operation in a similar way and the same quality. And the view on those patients, obviously, the pelvic view with the robot gives you a better choice of better to look at the planes, and obviously you can do a better job. The preservation of nerves and going to the right plane is obviously can be done with both approaches, but it will be much easier. And this is a lower rectal cancer, and you can see what I wanted to show, that how robot makes life easy when you divide the rectum with the short form, with the robotic, which is a robotic stapler, and this will show you how easily you can just deploy this. And it makes it so easy for you, and just been checked. So this is another trial which is just published this month, which looked at the clinical effectiveness of robotic versus laparoscopic and open approaches. They included 60 cases. 60 studies, and this is unique in a way that it looked at not only colorectal cases, they looked at the gynecological cases, upper GI cases, and hepatobiliary cases. And the red markers are showing where the robotic approach was negative, or given a more was negative. For example, more operative time. But if you look at the rest of the colors, yellow is where it is neutral, and green where it is positive and favorable for a robotic approach. And you see that majority of the map is either green or yellow, and that also indicates that robotic approach is much better. So what about the surgeons who are performing? This is my other previous supervisor performing private operating on a very high BMI patient with a congested theater. And this is Irshad, who is another colleagues and my mentor, is performing. And you see how comfortably both are. One is obviously, you can see, so stressful. So the rise of robotic colorectal surgery can also offer a better working and better life to surgeon as well as to the patient. It improves the ergonomics and surgeon comfort. It reduces the occupational injury, and obviously it prolongs the career of the surgeons performing those procedures for a longer time. So RAS has a significant impact on surgical workforce. This is another survey which was very recently published, and it was conducted amongst a number of surgeons performing abdominal and thoracic surgeries. And it shows that the burnout and being close at the work and stressful surgery is much more better related to the robotic surgery. And this is another important aspect which we need to look at. Let's look at the adaptation. So over 20 million robotic assisted surgery being performed over more than 30 countries using the Da Vinci system. Just last year, 2 years back, 1.5 million procedures are performed by the Da Vinci. The market size is over 19 million pounds, which you cannot deny. And what are the different type of the robots? It's been flooded by the number of robots are coming in. This is one who use XI system. 25 is in the market, and he been FDA in US, and very soon will be Europe. CRM is another robot which is in a clinical practice. A number of centers, including Pakistan, acquired it. And Hugo Ross is also another robotic system which is getting approval and being practiced in the UK as well as in the Europe, and probably in the Middle East. Single port, where the future lies, is also has FDA and now is in the practice in a number of in US and probably going to come to Europe very soon. There are a number of systems which you were talking with colleagues, and this being one of them is the robot mantra from India, and this is the J&J's robot Avata, and there are some Chinese robots which are coming in the market. And if you look at the evidence for last 20 years, there are almost 69 different robotic systems to become in the market very, very soon. So next 2 years, probably you will have a lot of choice. So in the future perspective, integration of intraoperative navigation technology and AI-based holds a great potential for the surgical procedure, and the robot can offer you. AI will increase the safety of the robot, and its use will be much better and more useful in the future. And with the great competition of those number of robots being available in the market, that will decrease the robotic price, and this will increase the availability of those tools in the market in various countries and various parts of the world. However, they are not going to be cheap. They are still going to be very expensive tool, but obviously, if the governments and the health system can work on those policies, they will be more acquirable for many institutes like Shaukat Khanum. As soon as the market is going to be favorable, robots are going to be here, and they're going to be adopted by many surgeons. I think that it is also very important to develop the training programs and integrate those training programs into curriculum to a validated program. So as a conclusion, I would say that the robot has and always give you a superior dexterity. Its vision is better, and you can perform a better procedure, and obviously it is associated with a less burnout of the surgeon. Robotic surgery is the road, not the destination. Adopting robotic surgery is the right path. Robotic surgery is the present and not the future, and ROS is going to stay. Either you like it or not, you adopt it or not, it is going to stay. Just imagine if you want to apply as a colorectal or GI surgeon in any country, Asia, Europe, America, and you say, I do not do the laparoscopic work. They will not be interested in you. 5 to 10 years time, if you are going to apply a job, and you are not going to say that I do not know robotic surgery and are not willing to know, then you are not get a job. Thank you very much for your attention. I leave you with this quote from Einstein. Thank you.
Thank you very much, Jamil. Thank you. Thank you. All right. So let's start the question answer session. Any question from Dr. Farhan Rashid? Anybody?
Or for that matter, anyone, just say. For that matter, any comments, question to the people who presented? Yes, please.
Yeah.
Yeah, come and introduce yourself and then.
My name is Fahad. I'm working as a consultant surgical oncologist. I have a question from you, Prof. You said that T3 N1 CRM clear patients should be, and we should be inclined towards doing it upfront. So am I, right in deducing that you don't believe in watch and wait or something like that? Yep.
No, we do believe, because we run the big international watch and wait database. So, even if I don't like it, I have to commit to it. So people who are facing a permanent stoma in our practice and they are looking for organ preservation, they, by patient choice, opt to have neoadjuvant treatment in case they get complete clinical response, and we can put them into the program. So this is patient choice. But if you are able to do sphincter preservation surgery, then this is what we advocate, this is what we practice. Yeah, sure.
Right. So if I'm to be here from Shaukat Khanum, Peshawar as well. So I've got a question for Nick Maynard, and I've got a question for Jamil. And I'm hoping for a little slight small debate here.
So maybe our
Right.
colleagues can come to the podium. So
Maybe
thank you.
that might be better. Right. So I know the robot's here to stay, and if you don't know how to use the robot in 5 years' time, you will not have a job. But I have a slight dilemma with believing in a lot of the data that's coming through for the robot. Now, I know in expert hands, it might be an amazing tool, but when you look at the data in detail, it seems to be more industry driven, and the results don't seem to match up in successive publications from various units. And I know we've had these discussions outside of these meetings as well, and I would like to know just how both of you would kind of either bat for one side or the other side, and see where your thoughts are on that, because I know the dilemma is very conflicting, and if for people like us who may not understand research that well, I would like to know what the ground reality here is.
So, great question. I'll make a couple of declarations. I'm not a robotic surgeon, but our unit has embraced it wholeheartedly. I'm not doing it because we've got limited capacity, so my younger colleagues are doing it. And I passionately believe that robotic surgery is here to stay and will be the future for much of surgery, not all of surgery. Having said all that, I know very, very well that despite what is sometimes published and people say at meetings, the real world data in the UK from robotic surgery for the esophagus is not as good as might be believed. And that's not to say people can't, but I know individuals who get fantastic results, but I equally well know that the vast majority of units have had some very difficult and challenging times with it. So I think the premise of your question is absolutely correct. And in some centers, but I mean, let's take Holland, for example, where they have really pioneered robotic esophagectomy. Their anastomotic leak rate remains consistently about 20%. And I know that's the case for many robotic units in our country. I do believe it can be done brilliantly. I know individual surgeons who are getting fantastic results, but I don't think that's necessarily happening in the real world. The final comment is what I alluded to in my talk. I don't think, and this is just from what I've seen of seeing some people doing it, that attention to those particular details which I obsess about and at the end of my career, I don't think that's being done with both robotic and minimally invasive resections.
So I just obviously I'm just going to gear towards the colorectal surgery, but it's the adaptation of robotic upper GI and HPB is still in a very initial stage. It's not as urology as colorectal. Should I tell you, do you know that the Alcott trial and there's another Australian trial for a laparoscopic versus open published in the New England Journal and the JAMA in 2022. And what they said is that open surgery is superior to the laparoscopic. Would you still believe that? But you still do the laparoscopic surgery. And the people who do the laparoscopic surgery, they believe that it's better for their patients. But if you go to Basingstoke, they do TME open and they still do it. But in the outside, the data is amazing and they're comparable to any world data and better than that. And it's a tool. And if you do well, and it will produce the results. The basic and when you look at the various evidence in the various center, it varies. And as it's so depending upon who is doing it, where this has been done, it as Nick said, it's very important. And data will be always like that. It's same after 40 years for a laparoscopic surgery. It's going to be for robotic surgery as well, and it's going to carry on. But the people who are going to adopt, they will show that they are doing a much better job. I can tell you from 2 years been doing robotic surgery. I think my robotic procedures are much better than laparoscopy. Although I had my clinical outcomes are almost same, but I feel myself more comfortable doing that.
All right. Amjad, will you like to comment on this as well?
Okay.
As it is your field as
All right.
well.
No,
so-
no. Okay. So first part is being a single provider for 20 years. It is largely driven by industry. They would make the surgical community believe that they have become a new animal. They would also make the society believe that this is the best operation to do. So there's a big advertisement industry that follows the robotic surgery. So it's funny that they don't invite me anymore in their symposiums, because for years I looked at it very objectively, both laparoscopically, because I really was not interested in colorectal surgery. I came to work with Merv Rees at Basingstoke as a research fellow, and one day they were shot in colorectal theater, and I went to help with open TME to Bill Heel and Brendan Moran. So I was that guy standing between the leg with St. Mark's retractor, always just pulling, not knowing what they're doing. And I was the first guy when they said, both of them, they were doing a live MDT operating. And Brendan said, I think we are below the tumor. And I was the first guy who agreed immediately without knowing, without saying, because I wanted this damn thing to finish. And Brendan Moran said, this can never be done laparoscopically. Look at the retraction that we have to put in. So I thought I'll do colorectal surgery because it's a fun operation. And that's why I became colorectal surgeon. When the robot came along, we had done close to 1,000 laparoscopic TMEs, and we published it, and we thought we're pretty good at it. So I thought I don't want to do robotic surgery because I have to learn something new. And our conversion rate, local recurrence rate, everything was pretty decent. To improve those numbers, you have to sort of become something extraordinary. The point I'm trying to make is a difficult operation remains difficult, no matter how you do it. It becomes less difficult with right tools, but it never becomes easy. If anybody tells you it becomes very easy with laparoscope or robot, I think it's not correct. So what I have looked at my data, nearly 1,000 odd, and I think Oves is going to publish this soon from Birmingham. He's working at the moment, one of your previous fellows. Short-term outcome, marginal gains, there are values, subset of patient, obese patient, right-sided tumors, low tumors in rectal cancer, no difference in oncology. Why it should be? The tumor has not changed. The biology have not changed. If my margin rate goes up, it is a bad technique. So, if your CRM dissection margin, laparoscopy in a good unit is under 5%, robot has got very limited improvement to demonstrate. So you have marginal gains with the technique. You have to be honest. The marginal gain theory, I don't know whether you are aware of it or not. This is British cycling story. Nick would know it very well. We didn't have a gold medal in Olympics for about 100 years. And suddenly they have got one guy, a ruthless guy, who broke down the art of cycling into 101 modules. And he said they would improve 1% of everything. Not a lot, 1% of everything. And they had what, 12 gold medals, I think 2012, London Olympics. So this is what the marginal gains are. It's a purposeful, repetitive movements demonstrating the same technique over and over and over again to show small change.
Just on that, my 2 pence, being the most junior one here, is the main advantage of the robot that I see is the longevity of the surgeon, the improving the life quality of the surgeon. And like, by the time we're done with the laparoscopic surgery, you're taking 2 Panadols and 3 Brufen and God knows what else, and then limping to work in the morning. So why aren't more surgeons more vocal about it from that perspective, that yes, the patient may be getting marginal gains, but it's actually the surgeons who are going to get the most benefit out of this. Your workforce is going to stay for another 10, 15, 20 years without having a broken back or swollen knee and all those things. But I see like we're pushing more of this on the patient rather than for our own benefit.
But Farhan want to say something, maybe, yes. Come along then.
Basically, a lot has been talked about colorectal robotic work, and just answering to Irfan's questions about robotic work in upper GI surgery, as Professor Nick Menard said, that the outcomes obviously are still looking into it, but having robot at a bariatric unit and not having robot at a cancer unit. So we are in the phase of going through the training on the robot for bariatric work. I must say that the robot for hiatal work is amazing. It's just like your pelvis.
Yeah.
If you've got a robot, you can deal with hiatal work beautifully. If you want to mobilize the esophagus in the chest, it works beautifully. But when it comes to putting the foreign objects in, you're going to put a feeding jejunostomy tube and things, it's fiddly. It's fiddly. But if we are going to say as an upper GI surgeon, we're not going to use robot, I don't think so that is right. As Jamil said, 10 years down the line, you may not get a job. So that's where we stand. I thought it was important to say it from upper GI perspective. Thank you.
So, and now my last comment is something that the young guys sitting here wondering, you know, in the next 10 years, they're not going to have access to robot, how they're going to become futuristic surgeons. Don't get upset with this. When I proposed laparoscopic TME to Brendan Moran, he said, a fool with the tool is still a fool. So make sure that even if you adopt robotic surgery, learn it well and do it well.
Can I make one further comment? I love those comments. And I just say again, I'm not a roboticist. I absolutely agree. It's here to stay and it will be carried out for a lot of surgery. But it's driven, as you say, it's not being driven by patient outcomes. It's being driven by industry, market forces and patient demand. And we're seeing lots of examples in the UK now of the intuitive representatives from the firm really putting pressure on surgeons to do things robotically. I think it's a really worrying trend how it's being managed at the moment.
Thank you very much. Yeah.
May I make a comment, please?
Yeah.
And I've asked Irfan's permission to make a comment from the HPB side of things because I'm not part of the panel. But I thought it's important to bring this HPB viewpoint to the discussion as well, because I am a robotic surgeon and I have been practicing for the last 3 years, and we do regular Whipple's procedures as well as liver resections. As far as the evidence goes, there's nothing tangible that shows that the robot is better than open or laparoscopic surgery in HPB surgery. That's one. It is very disruptive when it comes to training because we currently work as a 5-surgeon unit, but only 2 surgeons operate. And it's always consultant driven because industry dictates how the training goes. And as such, we have a list a week, and therefore we lose one whole training list, which we normally rate very highly, and therefore training has suffered in the unit. From the surgeon's point of view, I feel that it's more, and now I'm speaking about Intuitive because some of the other platforms are better, but Intuitive is very isolated. You sit in this little module, you are no longer in a social environment that is enjoyable in theater. So I hate my robotic list because I'm isolated. I'm completely cut off from even the anesthetists and even the others who are normally interactive, and there's very little training. If it's a dual console training, the other person's opposite you and you don't even see the person. And at the end of the day, I have more body aches and pains than when I had open or laparoscopic, because you are cramped in a position and you forget to move around. So I do not see an advantage, and now I'm speaking personally from the robot point of view. So I come back to what was initially said by one of the panel, and that is it has a place in some surgical specialties, not in all. And that is something to take away
Thank
from
you.
this. Thank you.
Thank you very much. And this discussion can go on, and we all love it, but we have to listen to Professor Nick Maynard, he is going to talk about Gaza next door. So let's move on to that side. Thank you very much.